So now moving to the management. So what we do with this. So first, the absolute most important in the first step in managing nausea and vomiting, if possible, try to identify and correct the underlying etiology. Just like dyspnea, if we can treat their infection or resolve their constipation and then their nausea goes away, do that first before trying to directly target their nausea with medications. But if you're in the midst of trying, or it's refractory nausea that you can't improve by treating the underlying disease, then we move to pharmacologic treatments. And this should always be based on what do I think the cause is and what receptors are involved in that potential cause. So those are the two questions that you always need to ask yourself before you write for an antiemetic or before you write for an anti-nausea medication. And then another thing just to keep in mind, what we'll often see is when we get consulted is the patient will be nauseous. They'll try a low dose of one medication. The patient will take one dose, maybe vomit half of the dose, and they'll say, okay, that one doesn't work. They'll go to another one. They'll try a low dose. They'll only do it once. And by the time they call us, they've tried 3 or 4 different medications. Do you think that patient has truly refractory nausea?
No.
No. Why? What was the problem? So they never gave them an appropriate dose. So always, in general, once we pick the one that we think is going to be the most effective or is the appropriate agent for that patient, you make sure they get the dose and you give more than one dose and you increase the dose before you start running to another one, because pretty soon you have multiple agents, you have multiple side effects to worry about, and the picture can get very blurry. So the first step is be very thoughtful and specific about the medication you want to try. And if you've committed to that, increase the dose either until you hit side effects or until you get to a dose that you feel that this agent definitely isn't working, and then switch to another one. But I wouldn't just keep adding more and more medications in a patient with severe nausea. I would be more thoughtful about what you pick and increase the dose first. Occasionally we have to combine antiemetics, but it's not common. I would say that's far more the exception than the rule. So these are some of the common ones that we use. I'll check just because in general, in my experience, when I've been in parts of Africa, there's usually 2 or 3 antiemetics in each hospital that they regularly use. So if I can just check, what are the most commonly used medications you all have to treat nausea? Metoclopramide, okay, perfect. We'll talk about that one. I assume do you have access to haloperidol?
Yeah.
You ever use that for nausea?
No.
Yeah, so that can be a addition from today's. Otherwise, any other medications that you will sometimes use?
Promethazine.
Promethazine, perfect. And do you have any access to ondansetron or any serotonergic
Yes.
receptors? Which one do you have? Ondansetron, Zofran? Okay, and not Grazitron? In Jamaica, they use Grazitron for some reason. It's very similar to ondansetron. Great, so you have all the main ones, and then I very much assume you have access to steroids and are using steroids. Yeah, perfect. So you have all of the sort of main and the most important ones. The thing we'll talk about a little bit more, so haloperidol obviously is an antipsychotic, and I'm sure your experience is more in using it for psychiatric conditions or for potentially delirium. So haloperidol is actually a very effective antiemetic. So as we talked about, largely in toxin-related nausea, that's mostly dopaminergic, and haloperidol is one of the cleaner and more direct anti-dopaminergic medications that we have. So haloperidol can actually be very effective for particular causes of nausea, which we'll talk about. So also antihistamines like promethazine that you said you all have, anticholinergics we will sometimes use, anti-serotonergic antagonists like ondansetron can be very, very helpful. And then metoclopramide, which actually has a little bit of anti-dopamine activity as well as being a prokinetic agent. I think we mainly think about it as a prokinetic agent. So for dysmotility, it's very, very helpful, but also does have some anti-dopaminergic similar to Haldol. So can be a very helpful medication. So this just gives you a quick idea of which receptors these medications hit. So chlorpromazine or Thorazine, do you guys ever use that?
Yes.
Okay, so it's a stronger antipsychotic, but it also hits some other receptors. So here you can see metoclopramide, which you'd certainly use. It has a little bit of serotonergic, a little bit of dopaminergic, and primarily it promotes gastric emptying. So it is a really effective medication. Haloperidol is much more directed at just dopamine. Thorazine has a little bit more of the histamine and acetylcholine in addition to the dopamine. And then ondansetron is very directly at the serotonergic. And then we have some other medications that we will, and then promethazine is largely histaminic. So you have sort of the main ones here, which is wonderful. Example doses of just how we will potentially use these. So I think the main one is just to introduce for haldol, because my guess is you're very comfortable using all these other medications. So we will often start with 0.5 to maybe 1 milligram, either PO or IV, and often IV if the nausea is severe because they can't keep the pills down. And I would just add it for a patient that you think has nausea that's largely dopaminergic, so toxin related. So think renal failure, potentially from some chemotherapies. Those sorts of things, haloperidol can actually be very, very effective. So this is just an example. So this is from Hospice Africa. This was from the Palliative Care Service at Mulago in Uganda, so a place that I've worked and practiced with some of those colleagues. And just to get an idea of how they think about it. So they try to think, is it gastric stasis or delayed bowel transit time? Is it GI inflammation? Is this more metabolic disturbance or toxins, or potentially raised ICP? Similar, they try to think, okay, what is the cause? And then they move to the treatment. And as you can see, for metabolic disturbance or toxins, they do use haloperidol there. And at their national hospital, they actually use haloperidol quite a bit. So just, I think, something to add to your repertoire. And again, like we talked about, if it's truly refractory and you're using one of these, I think the most important thing is to stick with one agent and increase the dose until you start to get side effects. One thing to absolutely keep in mind, so if you start to have really severe nausea, just looking back at this one, when you're using medications that hit similar receptors, that's where I want you to especially have some caution. So for example, say you have a patient that has some dysmotility, but you also think some of it could be toxin related and you choose to use metoclopramide. Keep in mind that metoclopramide also hits dopaminergic receptors. So I, in general, wouldn't use metoclopramide and then add haloperidol on top of that, because now your risk of extrapyramidal symptoms and other side effects from that dopamine blockade goes up quite a bit. So I would absolutely keep that in mind. And this is why I try to stray away from using multiple antiemetic medications at the same time, because the receptors can start to get messy and your risk of side effects goes up a lot. You're much better off being very thoughtful of which one you pick to begin with, and then slowly increasing that dose as opposed to trying to add multiple medications on top of each other. And then ultimately, if one is not where, yes, hand, please, question.
There's a slide in which we have haldol as sub-Q.
You have sub-Q?
Yes, one of those slides.
Yep, so it can be given sub-Q. So I think in general, so long time ago, 20 or 30 years ago, there was a concern about giving it IV, but it's perfectly safe to give IV. We do it all the time. But in some places, they still give it sub-Q more often. I think it's appropriate either way, but if a patient has an IV line, there's no reason to give it sub-Q when you can also give it IV. I saw another hand? Or was that stretching again? Okay, no problem. So we're coming near the end. And again, so as we talked about, I guess last two things. So the other piece to keep in mind is sometimes we can use the side effects from the medications to our advantage. So for example, if you have a patient with nausea that you think is largely from GI stimulation, so we think serotonergic, and also they have diarrhea, and it would be helpful if they were a little bit more constipated, then ondansetron is a wonderful medication for you. So one, I assume many of you know, but a common side effect of ondansetron is constipation. So in patients that are on opioids for their pain, say a cancer patient, they also have some constipation and now they're nauseous. We will sometimes use it, but in general, I would try to avoid ondansetron because it will significantly make their constipation worse. Another example is if you have a patient that's very nauseous and is maybe teetering on delirium or is very, very anxious, haloperidol could be very helpful for you because it's relatively sedating. Yep. Hello, can you hear me?
Yes.
Yes.
I see somebody at the computer screen.
Or change something that popped up.
Should I pause for a minute?
No, just continue.
Oh, just continue. Okay. And then the last piece, just as we were talking about, So I would try to avoid using multiple agents all at the same time, and in general, increase the dose of one. And then if you really don't, it's not working and you have side effects, think about just rotating to another one as opposed to adding them together. So a great example would be if you're using chlorchlorperazine, which we use a lot, or compazine, we use a lot in the US, and then metoclopramide and haloperidol. So those all have partial, haldol a lot, of dopaminergic activity. Your risk of having side effects if you put all of these three together would be it would be very, very high. So just another thing to keep in mind, don't just keep throwing the kitchen sink at these patients. Stop, go back, ask yourself which receptors are involved, and then try to pick the best medication at increasing doses of which receptor you want to target.